body. So that was called a heterotopic liver transplant, because like in the kidney nobody takes out the old kidney, you just put the new kidney in another place. But the liver is such a complex organ that it needs to be where it is. It needs to flow into the IVC, it needs to get blood supply from the portal vein, and if you put it somewhere else, even though it has got blood supply, it doesn't do well. So heterotopic liver transplants died 1980s, and we stopped doing them, and after that we've always done orthotopic, which is putting it back where the old liver was. We have to remove, that's what you saw in the pictures. So that liver was taken out and an empty space is there, and we put the new liver in that space.
Where are you practicing so that we can refer the patients to?
So we have started a small liver center called South Asian Liver Institute that is in Banjara Hills. So you know the new Rainbow Children's Hospital? Yes. It's right next to it. So my point of starting that institute was, I think 85% of liver disease, if we can get it early, we can get it to reverse, because the liver has got a better regenerative capacity than any other organ in the body, except maybe the skin. The skin is the only one that's got a better regenerative. So there are experiments where they have taken a rat, removed 90% of its liver, let it walk around. 2 weeks later, take the same rat, remove another 90%, let it walk around. It will grow back to 100%. Take the same rat, cut it again, 90%, it will grow back to 100%. They did this experiment on the same poor rat 16 times. And the 16th time also, it regenerated. So my point is, unlike the lung that doesn't have that kind of capacity, the liver has got great regenerative capacity, except we need to get to the liver before it reaches the cirrhosis stage. So fatty liver, grade 1, grade 2, grade 3 is okay, we can reverse it. Even fibrosis, grade 1, grade 2 is still okay, we can still reverse it. But once you have cirrhosis, it is irreversible, and then transplantation becomes the only option.
Stem cell should work.
I have not seen a success with stem cell. You see, there are funny things. Ayurvedic treatment. Everybody knows great popularity for Ayurvedic treatment for jaundice, correct? Why is that? Primarily because of hepatitis A and E. If somebody gets hepatitis A, if you don't do anything to him or her, he will get better 90% of the time. So, if 60% of them get Ayurvedic treatment, he will also get better. So that's how Ayurvedic treatments got such a fantastic reputation for jaundice. It actually does nothing for jaundice. I don't know of a single chemical that reverses jaundice. In 80 years of medical research, billions of dollars being spent, don't you think they'll find it? If it was there, they can become richer than Elon Musk. So they haven't found it because it is not there. And therefore, stem cell therapy. There are some acute liver failures like A and E that get better. Some of them get stem cell therapy and some of them get better. But show me a paper that consistently has shown stem cell therapy to improve. It doesn't exist. There are 40,000 papers written every year. Not a single paper for the last 6 years that has shown outcomes that are good for stem cell therapy. How can we give this and charge a patient for it? That's my view. Great question. I mean, this is one of the reasons we started the Liver Institute. These patients don't need to come to the Liver Institute. But what we have done is start that program. What we simply do is, let us say you are seeing a patient and the patient lives near your hospital or your clinic. So what we are trying to do is, first of all, grade what stage of fatty liver disease that patient is in. So as soon as we know the grade, then we start the treatment. And then we do regular reviews to see direction, we check, was there anything else? So because some patients with fatty liver disease can also have hepatitis B, so we check for these things. And one by one remove all the risk factors for this until we can get it right. And even in grade 3 fatty liver disease, we can bring them back to a normal level. So what I suggest is, if you're seeing patients with fatty liver disease, maybe what you could do is see them maybe every 2 months. And we can see them once in 6 months, so that between you and me, we can try and get that patient back to normal without a transplant. If the what? Saying before, weight loss, sugar control, and maybe a few antioxidants like Evion, vitamin E, etc. That is, many people say, is that all? That is enough. That will reverse it. There are some people with a genetic predisposition. Those are the ones, despite this, will progress in the wrong direction. Those are the ones that we need to see as well.
Sir, the other day I was listening to a surgeon who was telling that patients with who are likely to have contraindicated to do an invasive FNAC, or what's your take on that? Is it justified to take a FNAC of a pre-existing cancer?
So, it's for cancer. The truth is, now we have such fantastic scans, a combination of a high quality CT, triphasic, with if necessary an MRI, followed by a PET scan. 95% of cases, we will know what the diagnosis is.
Does the invasive procedure aggravate the...
It can do. There are two problems. One is it can seed tumors to other parts of the peritoneum when the patient becomes inoperable. Second possibility is, because many of these patients have got cirrhosis, I have seen many people who had a biopsy and then they had a bleed that wouldn't stop bleeding. And very rarely, mixed tumors, some strange neuroendocrine tumors. Those are the few tumors that we have done biopsy. That also not to get the diagnosis, more to know the biology of the tumor. Is it KRAS positive? Is it CDX positive? If it is CDX positive, then the chemotherapeutic regime has to be changed for that reason, not for diagnosis.
So, being associated with the Jeevan Dhan program at Prince,
Yes.
I would like to ask you how often you transplant cadaveric liver and how often you get a live donor there. Because that is very important. What I feel is many people don't have that idea that even after donating their liver, they can survive a very normal life.
Absolutely, absolutely. I'll tell
And
you.
one more thing is that 1700 odd liver transplant in India.
Yes.
Don't you feel is that too low a number for a country like India?
100%.
So that again focuses on the life.
100%. So I'll answer that first. So if you count UK, a country of some 55-60 million people, compared to India, 1.3 billion, we should be doing approximately 35 to 40,000 liver transplants every year. We are doing 2,000. Primarily not because of organ shortage, primarily because people are not getting the right advice and people can't afford it. These are the two key reasons. Because this 2,000 transplants that you saw, 80% are living donor. Of the 270 transplants that I have done, 70% are living donor, which is a tragedy, but the truth. Therefore, one is the organ shortage, second is lack of right information being given to the patient. So, many patients are being told, you got a little bit of ascites, or you got a little bit of viruses. We can control that with banding. Who doesn't know you can band? Of course we can band, but you can band once, you can band twice. If they are having further bleeding, if despite diuretics they are having ascites, that's the right time to transplant. If you continue banding, continue ditor, they will become like the man you saw in the picture, no muscle, ascites, hepatorenal syndrome, renal failure. After that, what transplant? Who can do a transplant? These patients will die, they will come to us, I will say you're too sick for a transplant and we can't do a transplant. I can't tell you the number of people I say this to. And they all say, sir, we have been seeing doctors every month for the last 7 years. But they did not tell us about this. In 2020, this is, I told you, referral patterns is the biggest issue. And not organ shortage. Organ shortage is a problem in the sense that we are unnecessarily using a family member's organ, but it is not actually reducing the number of transplants. What is reducing number of transplants is that connection between a good transplant center and a liver patient, and number two, costs. As you know, we both worked in Nizams, we still work in Nizams, and we started a free government program in Nizams 2016, and we have done about 12 transplants completely free for the patient, but the program is not doing that well. We are not doing that many patients anymore in Nizams. But I was trying to do something where we do something free for the patients, but as you know, government sector is not easy and many times it doesn't happen.
Immunotherapy.
Sorry?
Immunotherapy.
Immunotherapy. For liver disease, autoimmune hepatitis has got very good outcomes with immunomodulation, both with steroids and azothioprine. Some children, not that many children, PBC, again, you can have some benefits, but not many other diseases. Testing for hepatitis B and C enough. 400 million with hepatitis, 100 million plus 70 million, there's 200 million people in this country with hepatitis B and C. Shouldn't we test everybody? How many of us have had hepatitis C treatment, testing? How do you know? Some barber, some contact. How do you know? And why haven't you tested? If we are not testing, what is the hope for somebody in the market out there? Strange question. Must be, should be. And I think these serological tests are not so expensive. You don't need the DNA test. You can just do the surface antigen first. And you pick up 95% of hepatitis B. So it should be. I don't know how many of you know, but if you look at the last 25 years of hepatitis B in our country, vast majority is from mother to child. Not from IV drug abuse, not from barbers, it's from mother to child. And the poor mother doesn't know. And that's how the child gets it. And because it has got it from the mother at a very young age, the response is very poor. And those children develop chronic hepatitis B easily, without any symptoms, without jaundice. And by the age of 20, 25, they are cirrhotic. So, maybe 6 months, one second, I'll come to you. About 6 months ago, when COVID was at its peak, I wrote an article in the Indian Express, I don't know whether anybody saw it. It is called Hepatitis or COVID, which should you fear more? Because by far, you are more likely to die of hepatitis B than COVID. Yet, what is everybody talking about? COVID. The social media effect. Sorry.
Like you said, the mother of 22 months of this is dead. Didn't you educate her before,
We did, before everybody goes home. Not only are they told, they are even given photographs of every tablet. They are given in printed form. Not only the mother, the father, some auntie. So we tell everybody in the family, so that even if one were to forget, the other would not. But when they see a child who was very sick being well,
Get better.
they get overconfident. And don't forget, these tablets are expensive. They cost about 2,000 to 5,000 rupees a month. So this family wasn't that well to do and they thought 6 months the child is fine, we'll try it out. And the problem is, she didn't tell anybody else that she is not giving the tablets. Because I think she found out that she did the wrong thing. And then she didn't want to get into trouble, so she kept it quiet and quiet and quiet. And only when she reached ICU did she quietly say that I have not been giving her the tablets.